Low back pain is one of the most common musculoskeletal diagnoses in the world. How can a physical therapist help with your low back pain? Let me explain. My name is Nick Helton and I'm a physical therapist. I'm making a video series about low back pain and the physical therapy evaluation of low back pain. A physical therapy evaluation is just the process or the name of the term for the process of seeing your physical therapist and having your physical therapist evaluate your pain, your symptoms, and get an idea of your background. Today I'm going to be talking about the objective portion of the evaluation. If you want to see the subjective portion or the beginning portion of the evaluation, I suggest checking out the video that I have in the title cards above. But today we're going to be going into the objective portion of the evaluation. What do I mean by the objective portion of the evaluation? So the objective portion involves collecting objective data. This can be in the form of manual muscle tests, range of motion assessments, or what is known as special tests can also be included within the actual treatment session. I'm going to go into special tests and why I don't think they're necessarily a very good option for physical therapists, but I will talk a little bit about them specifically. Hopefully at this point you've already seen the subjective portion where I go into detail how I start the evaluation. Now I want to catch you up to speed with the objective portion. Important disclaimer that I need to throw out here, there are no cookie cutter programs that cover every single individual aspect of what needs to be performed during an initial evaluation. I just want to give some of the highlights and things that typically occur. There are cases where some of these things do not occur, and there are cases where there are a lot more things that need to occur. It should go without saying, but humans are different. There's a large degree of variability, and I can't cover every single individual aspect of what might occur in evaluation. I just want to give, again, the important highlights. Typically, as I begin the objective portion of the evaluation, I like to start with gait. So I'll have the person walk roughly 30 to 40 feet in one direction and walk back towards me. Now, as a note, I'm not overanalyzing biomechanics when I'm doing this. I'm not looking for perfection. I'm simply just getting an idea of how that person is moving. Are they apprehensive to push off onto their toes? Do they self-limit upper back rotation as they're walking? Are they fearful to turn? How quickly can they walk? Are there any balance deficits? As they are moving around, do they seem steady on their feet? These are all just little things that I try to look for within the gait assessment. Next, I'll have them quickly turn around and walk back up and down the hallway while walking on their toes and walking on their heels. I'll have them roughly do that 10 to 15 feet. This gives me two things. One, I'm able to get a quick screen on ankle strength and balance, and two, it gives me more areas to screen if they have difficulty on one side, especially if that side maybe corresponds with some of their self-reported symptoms, numbness and tingling, decreased sensation, pain shooting down the leg, those sort of things. Those are areas that we want to screen further for consideration of things like lumbar radiculopathy and measures in that kind of spectrum, which I'll discuss a little bit more in a minute. Next, I'll often just do a very quick basic balance screen, just statically having the person stand on one leg. Again, this is not to find hard and fast diagnoses or to really try to say that there's an issue at hand, but I like to get a general idea of where that person is at. Can they perform these simple static sort of balance assessments? Things that I may be looking for while having them perform single leg balance: does putting all of their weight on one side aggravate their symptoms? Are they more stable on one side versus the other? Which again is not uncommon. It all depends on the individual. We all tend to not be perfectly asymmetric. I would say it would be almost completely unlikely that someone is perfectly symmetric on both sides. But again, trying to correlate perhaps some difficulty with unilateral stabilization in the static position with symptoms can be something to consider, not from a pain aspect, but more so from a function aspect. Next, I will start with functional screens, which the use of the word function at this point is almost comical to a lot of people. It's just a term in my head that I attempt to sort of justify activities that that person needs or wants to be able to do in their day-to-day life. This doesn't mean anything spectacular or over the top. It can be as simple as a body weight squat, going up and down the stairs. Can they lift an object up over their head with good range of motion of their shoulder? You know, those could be my functional screens. Or it could be something specific, like say a CrossFit athlete or a fitness athlete, someone who's in the gym could come in and say, hey, like I don't have pain with a body weight squat, but I start having pain when I throw 225 on a barbell. Okay, great. So that needs to be their functional screen because that is particularly what is aggravating their symptoms. And again, since there is such a wide degree of variability in terms of who comes in, what we're working on, if I'm working with a 25-year-old with no past medical history that just has some minor low back pain or a tweak here and there, that's going to be a different sort of first day evaluation than someone who is maybe in their late 50s, who's had a variety of surgeries, numerous comorbidities, who has trouble just even going up and down the stairs, right? Those two individuals, the evaluation is going to look very different, but we're going to have similar thoughts in mind in terms of the functional tests, or you could call them meaningful activities. I think that's probably a better way to put it. What is meaningful to that person? It could be, again, going up and down the stairs, or it could be putting 225 on their back for a bodyweight squat. But that's sort of where we dive into the differences in between individuals. And again, I'm not saying the ages, because ages do not inherently mean that someone is not going to be able to perform these activities. But I think the important thing to consider is the entire individual, right? Someone who's had a higher number of surgeries, has a lot of comorbidities, who is generally deconditioned, the screen is probably going to be a little bit more lower level than someone who is participating in like a competitive sport or a competitive athlete. Another important aspect of the evaluation is what is called an asterisk sign. So an asterisk sign is a particular self-selected activity that the patient has pain with, has symptoms with, is unable to perform for whatever reason, and that should tie into their long-term goals. Now, in the previous two examples, I mentioned an individual who just wants to go up and down the stairs, or an individual who could barbell back squat or wants to be able to barbell back squat 225 pounds, right? In both of those cases, that can be considered that individual's asterisk sign. Now, once we've established our asterisk sign, this is where things are extremely important, right? Can we perform an intervention and have improvement in that asterisk sign? Now, that's not to say that this intervention is fixing the person or some magical cure, even if it just decreases their symptoms by a small amount and they are able to replicate that or perform that on their own individually. To me, that's a bit of progress. And what I try and do is stick with that individual intervention until we've limited the benefit that we've gotten from that, and then move on, whether it's progression or regression or reassessment of what we need to do next. So here's how that would typically look. I want to give you sort of a breakdown, a little bit of an example of what that would actually look like in practice. So once we have the asterisk sign, we test and retest, right? I mentioned that. But the things that I'm going to be looking for. So can the person perform the movement with less weight without substantial symptoms? If not, can the person perform the movement with less range of motion without substantial symptoms? If not, we need to choose a movement that is similar, but non-provocative. So what does that look like? Let me give you a very simple example. So if that let's take the barbell back squat that I just mentioned. Can the person perform the movement with less weight without substantial symptoms? So can we put 135 pounds on the bar and have that person perform that movement? If yes, great. We've now just established a baseline and an entry point for loading. That's what we mean when we refer to things like that. Where is that person's barrier? What is their entry point? Now, if you can squat 225 for reps and we have to break that down and knock down the intensity down to 135, is that overly exciting for the athlete? No. But if we can load that athlete within a degree of tolerance without aggravating symptoms or regressing in terms of day-to-day activities, that's a great entry point. Now, if we can, or if we cannot take the weight down to a substantial point where that person can perform the activity without symptoms, then we need to consider limiting the range of motion. So in that exact example that I just mentioned, let's say that 225 is provocative, 135 is provocative, body weight squats are provocative. So all three of those movements, no matter what we did, we're still provoking symptoms to the point where they're a bit too high in that moderate to too high category. Okay, great. So now the next thing we consider is, can we limit range of motion? So in a squat, a simple way to do that is to do a box squat or a pin squat or something that limits the range of motion, right? So if I have that person perform a half range of motion box squat and they can do that with 225 without symptoms, excellent. That's another place that we can start. We're at least able to load top down. Yes, we're able to load the bottom portion of the squat just yet without provoking symptoms, but at least that's a great starting point. Again, the starting point in the long term is really not that important. It doesn't matter that 6 months ago for 2 weeks you were only squatting 135 if now you're up to back to the amount that you were at before, right? A single day, a single week, it really doesn't make or break your training or your individual activity. And that's something to really keep in the back of your mind, is that just because there's some temporary regression, it doesn't mean that the progression is not going to come back. I think that's a common sticking point that I tend to see with athletes. So within the third thing that I had mentioned, so let's take that the barbell squat again. So the person tried 225, they could not drop the weight and perform the squat even with body weight. We tried a barbell back squat to a box, so limiting the range of motion or pins or whatever, and they weren't able to tolerate that. Okay, the next consideration is, can we perform a similar exercise that will hopefully achieve similar results, but that is non-provocative? So in this example, let's say that we go from a barbell back squat where we have a posterior load, or more of a posterior load, I should say, to a goblet squat where we have an anterior load. Can this person who can't barbell back squat currently, can they perform a goblet squat? So let's give them a dumbbell or a kettlebell and have them do goblet squats. Can they perform that movement and have it be non-provocative? If yes, excellent, great. So now we've just gone through the categorization. We've gone through decreasing load, we've gone through decreasing range of motion, and if not, we selected a similar exercise. Now, how long does that person need to perform goblet squats for? I don't know, it depends. So it could be just a week or two while you let things calm back down and try and ramp back up. It could be for a little bit longer than that. It all depends on the severity of what's going on and how bad the symptoms are impacting your life. If someone has very severe numbness and tingling, loss of sensation, those progressive sort of neurologic issues, maybe it's a little bit longer. If someone just has an acute bout of low back pain that is probably going to regress to the mean and get better with time, maybe it's only 1 or 2 weeks. Maybe it's a very small amount of time. But really the important thing to consider is that every single person is going to have a different trajectory, and the trajectory is not always linear. Oftentimes it's very jagged. There's improvement and a slight regression. That's typically how most things go. It's really just a perfect linear line back to success. One more thing I wanted to mention about the functional screen or meaningful activities. It can involve a wide variety of things: lifting, carrying, pulling, pushing, squatting, hinging, or some combination of all those things. Those can all be on the table if that is a meaningful activity to the individual. Hi everyone, Future Nick here, and I was starting to edit this video and decided that it's getting far too long, so I'm going to cut the video right here. I'm going to split this up into 2 different videos discussing the objective portion of the evaluation, because I don't want to bore people with a probably 25-minute long video. Thank you so much for watching. Please stay tuned for part 2. I'm going to have that uploaded probably tomorrow pretty quickly. And again, I appreciate you guys watching this video.